My name is Tiziano Scarabelli, and I am the Director of Cardiac Oncology Services at Virginia Commonwealth University in Virginia, United States. I just presented my work at the 22nd scientific sessions of the International Academy of Cardiology meeting, and I would like to share with you some of the findings of my new work. Being a cardiac oncologist, I take care of patients with cancer and a cardiac condition which has been caused by cancer per se or the therapy of cancer, namely chemotherapy and or radiation therapy. And taking care of some of my patients, I realized that the infusion of a specific chemotherapeutic agent called CARFILZOMIB was causing chest pain in this population. CARFILZOMIB is a new proteasome inhibitor, and it is used for the treatment of patients with multiple myeloma. It is definitely very powerful, but it caused some issue in the patients which prompted further investigation. What I have seen is that sending these patients to the cath lab where an angiogram was done, no specific lesion in the coronary artery was found, which was suggesting a different role by means of which CARFILZOMIB could cause this type of side effect. So I started to investigate the physiological actions of CARFILZOMIB in a rabbit model of disease, and seeing that CARFILZOMIB could cause spasm of the coronary arteries. After that, in order to make more translational my findings, we moved into a study carried out in men. So patients undergoing on-pump cardiac surgery were used as donors of a very tiny amount of the grafts used during surgery for CABG, and this tiny amount of the arterial and the venous conduits have been tested with CARFILZOMIB to assess its action on these isolated segments of vessels. So what we have seen is that CARFILZOMIB had the ability to cause a spasm of both conduits. It was able to amplify the spasmogenic action of different spasmogenic agents, such as noradrenaline, angiotensin II, and serotonin. It had the ability to diminish the vasodilatory action of nitroglycerin, nisfadipine, and sildenafil, and also it was able to reduce by approximately 50% the vasodilation caused by acetylcholine, which is a well-known endothelium-dependent vasodilating agent. So why these findings are so important, and how can we use them? The importance of these findings stands in the fact that they should be used as a cautionary tale for the physician taking care of patients with multiple myeloma requiring CARFILZOMIB infusion. This concern of mine stems from two major observations, or rather consideration. First of all, multiple myeloma is a disease which typically affects the elderly, where there is a higher number of cardiovascular risk factors, or even well-established cardiovascular disease. And second, and I would say even more importantly, people with a history of a myocardial infarction or unstable angina, that is, people with a known history of coronary artery disease, were excluded from the clinical trials based on which the FDA approved the use of CARFILZOMIB in patients with multiple myeloma. So we do not know anything about these patients with a known coronary artery disease history, and we give them CARFILZOMIB, which at the current stage is not contraindicated. So this is what I want really to make clear. CARFILZOMIB should be given pending adequate cardiovascular assessment of these patients, which should go through an ischemic workup prior to the infusion, and maybe even monitoring during the infusion. This is not currently done, and before starting CARFILZOMIB, we need necessarily to know more to prevent, in any way we can, future cardiovascular complication. So, in a nutshell, I just want to conclude saying that chemotherapy is the cure for cancer, should be given all the time it is necessary, but my role, being a cardio-oncologist, is to say when this infusion, this administration of chemotherapeutic agent can be dangerous to the point of putting in jeopardy the life of the patient. And carrying out work at the level of prevention is going to be the key of the success.